Okay, so welcome to the Issaquah Senior Center. We're doing a presentation on understanding stroke with Jennifer Kurtz. So,
Kurt.
Kurtz. Okay, so go ahead, Jennifer. Thank you for joining us.
Okay, let me just make sure my, I'm not able to advance my slides. Give me just a moment. Okay.
Sometimes it can be kind of tricky, but if you use your mouse or press the enter key.
There we go. There we go. I think, as I think Karen, you were saying, we've all adjusted to using the Zoom and Teams and all other kinds of platforms, and we're all learning. So I think we're all giving each other the grace we need to work through these computer glitches.
And so
Catherine,
sorry, I should say, you know, I've never run a program. I mean, I've never run a Zoom program. I've listened. So that's much easier. So I didn't mean to think that, you know, to say that everybody else.
Oh gosh, I didn't take it that way. I think we're all in the same boat. Yes, we're all in the same boat. As Catherine said, my name is Jennifer Kurtz. I am the stroke program manager at Overlake Hospital, and I did get to come out to your community a couple years ago and present on stroke. This presentation has been updated. Stroke has really been moving quickly. There's a lot of new data, a lot of new research, and month by month, year by year, we're doing more and more to improve the quality of life for people who do have stroke, and also, and I think more importantly for this group, to talk about what we can do to avoid stroke, or if we happen to have symptoms of stroke, know exactly what to do. So that's what we're going to talk about over the next hour and a bit. So feel free to interrupt me if you have questions. I think we have a small group, so I think that would be fine. Or if you want to hold off, we can have some question and answer at the end of the session as well. So this is what we're going to be talking about today. And then we're going to reference this a few times. Stroke detection. How can you tell if you're having a stroke? So let's talk about our statistics first. About 800,000 Americans have a stroke, or a new stroke, or a second or even third stroke every year. So it happens at a high frequency. Stroke is the 5th leading cause of death, which, you know, you don't want to make that top 5 list, but unfortunately stroke is one of the leading causes of death in adults in the United States. And you don't want to be on the #1 list either of the leading cause of adult disability. So stroke is the leading cause of adult disability. People who have strokes sometimes have very limited disability, but more often stroke causes quite a significant disability. 37% of Americans can't accurately identify even one warning sign of stroke. And whenever I reference this fact, it highlights for me exactly why I'm here and why I'm glad you're here listening to this presentation. Because if you or your friends or family can't identify a symptom of stroke, one of the warning signs, then how are you going to know that it's happening and what to do? And quick action is important. So we want people to know what warning signs of stroke are so that they can quickly act. So someone has a stroke every 40 seconds in the United States. If we started at 1 o'clock. We've been talking for 10 minutes. So that is at least 10, maybe 15, 16 people have had a stroke just in the time that we've been talking. And I like to look at numbers in the way it kind of apply it to people, because someone every 40 seconds is kind of, you know, it's hard to wrap your head around. But if you think of 16 people just since we started talking have had a stroke, it's a good way to really realize how common strokes are, how much and how often they're happening, and how many people they really do impact. We're going to talk a little bit about women and stroke right now, because stroke kills more than twice as many American women every year as breast cancer. And I think cancer organizations have done a phenomenal job in bringing community awareness to the breast cancer cause. And I don't think we've done as good of a job for stroke, because I don't know if it was a surprise to you, but it was a surprise to me when I first saw this, that stroke kills twice as many women a year as breast cancer. More women die from stroke than men, and women often suffer a greater degree of disability after stroke than men. And we're going to talk about some of the reasons for that as we go on. But this is the number one thing, well, I guess it's 5 things on the slide that I want to impress upon you all today, is what are the warning signs of stroke? Because if you know what they are, then you are much more likely to know what to do. So a lot of people have the idea in their mind of it's when, oh, somebody can't use their arm at all. The arm is completely weak, not able to move it, hanging by the side. Or that characteristic, you know, very clear droop of the face. So those definitely are stroke symptoms, common stroke symptoms that more people do recognize, but there are more than just those. So we're going to talk about that. It's sudden weakness or numbness of the face, arm, or leg, especially on one side of the body. So it's weakness or numbness. It's not necessarily complete loss of movement of the arm or the leg. I see, Karen, you're taking a drink of your coffee. We have a lot of people, or tea or water. We have a lot of people who come to the emergency department who some of the symptoms that they report is they try to pick up their coffee mug in the morning and it slips out of their hand. And they are kind of curious as to what's happening? What's going on? Why wasn't I able to hold on to my coffee cup? Why did it fall out of my hands? And they don't think, first off, this is a symptom of a stroke. It's more what is going on, rather than this is something to pay attention to. So another warning sign is sudden confusion, trouble speaking or understanding. So that is the right words not coming out, or even slurred speech might be a symptom of a stroke, but a sudden onset of that. Sudden trouble seeing in one or both eyes. We have a number of people who are sent to our emergency department every single year by their optometrist because they had a sudden change in their vision. And what did they think to do? Call their eye doctor, go in for an eye exam, and their optometrist sends them to our emergency department because, in fact, it's a stroke. So I think a lot of people always wonder, well, my vision changes. How do I know if that's a stroke or just my vision changing? That's what vision does. It's the sudden change. It's you're looking at your phone and then you look over across the room and it's different, or you wake up in the morning and it's different. So it's that sudden change that makes it significant and makes it possibly a warning of stroke. So sudden trouble walking, dizziness, loss of balance or coordination. You know, people who have blood pressure issues say, okay, that happens to me all the time. That's not a stroke. But a sudden onset of that that's not normal, that's not typical for you, and doesn't resolve quickly, that is something to pay attention to. And then a sudden severe headache with no known cause. People who have migraines have asked the question, well, I have severe headaches all the time. Are you saying I have to go to the emergency room, that's a sign of a stroke, and I need to call 911 every time I have a migraine? And what I'll tell you is that people who have migraines and people who've had stroke say, this was different than my normal migraines. So when they come to our emergency department, they know it's different. So if it hasn't happened to you, or if you are a migraine sufferer, I think I can confidently say that a headache due to stroke would be different than your normal migraine that you might suffer, a month or a couple a year. So let's talk about what a stroke is, because I'm a little bit of a science geek. I don't know if any of you are, but I think it's really important to understand what is happening when we're having a stroke. So we're going to go through a little bit of that anatomy. So a stroke is actually a brain injury, which is caused when a blood vessel to the brain becomes blocked or bursts. So this is a blood vessel to the brain. Can you guys see my arrow, that I'm moving my arrow? Yeah. Okay, great, thank you. And then right here is a blood clot. So ordinarily we would have blood shooting at a pretty high velocity through our vessels, going to parts of our brain to send oxygen to feed our brain. When there's a clot, you can see no blood's going to get past that clot. And so anything downstream from that clot isn't getting oxygen-rich blood, and as a consequence, is likely to die if we don't restore blood flow to that part of the brain. So here's another example. Here on the left side of your screen, everything is flowing beautifully. Here on the right side of your screen, that's where the clot is, right where my arrow is. And where it's blue, those are all of the arteries that are not getting oxygen-rich blood. So what happens when there's a clot there is that whole, essentially half of the brain, is not getting blood. And when our brain doesn't get blood, we see a sudden onset of symptoms like we discussed in that slide. The vision, the weakness, the dizziness, several of those symptoms, or even just one of them. So we have two types of stroke. One is called an ischemic stroke, and the other is a hemorrhagic stroke. And so one of our neurosurgeons, he's a really great guy. He talks about how his mother's upset because he tells people that he's just a glorified plumber, because he will take a clog out of a drain here, or he'll fix a pipe here. So with an ischemic stroke, what happens is there's a clog, like in your kitchen sink has a clog, and what do you have to do? You have to put Drano in it, or you have to use a snake or something to get that clog, or in this case, that clot out. Nothing's getting past that clot. In the same way for this ischemic type stroke, nothing's getting through past that clot and feeding the rest of the brain. The hemorrhagic, or the bleeding type of stroke, is when the pipe, like the pipe under your sink, bursts. So there's not a clot there, but there's a burst, and then all of that blood that would ordinarily pump through those arteries is actually, some of it is leaking and bleeding into the brain, as we see here. So the symptoms are often the same because you're getting damage to the brain in both cases, but the reason for the damage is slightly different, or actually dramatically different. So causes of an ischemic stroke. And so this is the clotting kind of stroke. So a thrombus, and here we see a thrombus, it's the development of a blood clot at the fatty deposit. So, you know, if you're going to see your doctor and having your carotid arteries checked, this is what clogged arteries look like. And so you see that the fatty deposits there create, or they actually narrow the artery. And so a clot is much more likely, a small clot even, is much more likely to get lodged there. Oops, I went ahead. Get lodged and then cut off the rest of the blood to the brain. You know, under normal circumstances, without those fatty deposits on your carotid arteries, that clot would be plenty small enough to pass through without any trouble. But because you've got a buildup of plaque here, that clot gets stuck. Another thing that can happen is an embolus can travel that's just too large and then will clot a little bit higher up in the brain. Some of the vessels of the brain, I like to think of it like a tree. Our carotid arteries here are almost like the trunk of the tree. And as it goes up into the brain, as the arteries go up and spread out, they're like the branches of the tree. So they're, you know, much smaller than the trunk, than the carotid arteries. And so a clot that might get through here in the big trunk or the big carotid artery is more likely to get stuck a little bit further up in the brain. So this blood clot, right, that we're showing right here, that's going to cause a stroke. A clot in your carotid can cause stroke, whereas that normal carotid just allows that, robust blood flow to the brain. So we're going to talk about the hemorrhagic type of stroke, the one that is the bleeding kind of stroke. You see here, we've got a burst in the artery of the brain, and that causes blood to leak in the brain. Blood is supposed to be in the arteries of the brain. It is not supposed to be in the tissue of the brain. So the brain does not respond well to blood leaking into the tissue. Here's another reason for a hemorrhage in the brain. I'm sure many of you have heard about aneurysms and aneurysms bursting. This is an example of an aneurysm bursting, where there's that kind of balloon or outpouching that can happen right here. If you see at the junction here, if any of you are familiar with engineering, you know that anytime there's a juncture, there's a weak point, or the potential for a weak point. And so that's what causes that, that aneurysm to kind of bubble out from the artery. And so long-standing high blood pressure can be a reason for why that aneurysm develops. But aneurysms are also, some of us are born with them and we never know it, and we never have a problem with it. But it is a vulnerable area if one is in your brain or develops in your brain, and it's usually high blood pressure that will push it to the point that it bursts, kind of like a balloon would under too much pressure. Many of you, I'm sure, have heard of transient ischemic attacks, or TIAs. Some people say, oh, that's a small stroke. I had a TIA, but I'm fine. Or my sister had a TIA, but she's fine. Here at Overlake, we see TIA as a warning, because if you see right here, we looked at this picture earlier, there's a clot. And when a TIA happens, it's the same thing as a stroke, but the person gets lucky. The body naturally, as a defense, will increase blood pressure just a little bit when an artery is blocked. And so sometimes it's just enough, because the clot just isn't quite so big, that the blood flow will push that clot through, and then we're fine. So what's really happening is that you've got all of the conditions are set up for you to have a stroke. You're having a stroke. You just got lucky enough that that clot was just small enough, or the blood pressure was just high enough to push it through. So you got lucky that one time, and you might not get lucky the next time, because whatever it is that's happening in your body that allowed that to happen once is likely going to allow it to happen a second time. So that really is, it really should be a warning sign. Usually the symptoms, or what's different from a TIA and a stroke, is that a TIA, those symptoms fully resolve. You go right back to normal. Now, I don't want that to be a reason for you to just wait. If you're sitting at home, or a loved one sitting at home and they've got those symptoms, those stroke symptoms, and you think, oh, well, maybe it's a TIA, let's just wait. Maybe it'll pass. Never, ever do that, because you are relying on or that's just flawed logic, because that is a medical emergency and you need to come to the emergency room right away. Because if you are having a stroke and that clot doesn't miraculously clear itself, then there are things that we can do at the hospital to dissolve that clot or to remove that clot that will result in a much better outcome and much less risk of disability. So another reason that TIAs are something that we really, really must pay attention to is that someone who has a TIA is almost 10 times more likely to have a stroke. And those are not good odds. So if you or someone you love has TIAs, make sure that they're working with their doctor to figure out why a TIA happened, so that they can reduce the risk of having a stroke in the future. So this is what we ordinarily think of with a stroke, is that drooping side of the face. And we ask people to smile when they're having a stroke. And that if that side of the mouth, or if one side of the mouth or the other doesn't go up, oh, that's a sign of a stroke. But remember, there's a lot more than just the drooping of a lip or an arm that's hanging by the side. So this is what our CT images look like for stroke. So when we have someone come to our emergency department with stroke-like symptoms, we whisk them pretty quickly. Like within 3 minutes of arrival, we've got that person in our CT suite getting a CT exam, because time is brain, and we want to figure out as quickly as possible what's happening so we can have a chance to reverse it. It's like a house burning down. You want to put the fire out as quickly as possible. You don't want to spend too much time figuring out what kind of fire it is. You just want to put the fire out as quickly as possible. So we move really quickly. In this slide here, this is what a hemorrhage or a bleeding from a burst artery looks like in the brain. So that fills up a lot of space in the brain, and then puts pressure on other areas of the brain that, even if it's not damaged or flooded with blood, it's pushed off to the side and compressed, which the brain doesn't like either. And so there's a change in function based on that bleeding. This is what a brain tumor looks like. The tumors are actually, I'm thinking the word pretty, but that's not right. They're just more symmetrical. They're not messy like this hemorrhage. A tumor is kind of all clustered together, and it's usually will look like a ball on a CT scan. So this is actually a CT scan of a normal brain. We've got this area in here where it's black. That's called the ventricles. That's an area of space that bleeding can go into, but that black right there, that's not blood, that's just space, and that's good. But the CT scan doesn't show us an ischemic stroke, the kind with the clot, because it takes hours and hours and hours for that brain to change enough to essentially die enough that it's visible on the CT scan. So if we don't know whether or not you're having an ischemic stroke from the CT scan, then what we do is a CT perfusion exam, and that's right after. The CT scan takes about 2 minutes, and then we roll right into the next one. So this CT perfusion, I kind of like it because it's colorful, but let me kind of talk you through it. See, all of these 9 scans here are different slices of the brain, kind of from top to bottom, and you see where it's purple, that is what we call ischemic core. So that is where we can see the damage to the brain that's already done. So that's a stroke in progress. What we see here is, in the green, is that's the area of the brain that will be damaged if we do not get the clot out. So we would much more, your level of disability with a stroke this size versus a stroke this size is very different. So the other thing is that shows us how stroke symptoms can get worse. You know, people will wait, oh, I only had numbness in my hand. I didn't come to the emergency room until I lost all function in my hand. Well, that's because what's happening is at the beginning, it's a little bit of damage, and then over a short period of time, that damage grows. So that is definitely a reason to not delay when you or someone you know or love has symptoms of a stroke. So it used to be about 10 years ago, and I've been working in healthcare for about 25 years. So at the beginning of my career, I worked with a lot of people who had stroke, and there was nothing that we did. You would go to the hospital, you wouldn't go to the hospital. It didn't really matter because there wasn't much that could be done. That is thankfully very, very different. Now we have a couple options. We have TPA, another, that's the abbreviated name for it, but the brand name is Alteplase. I'm going to call it TPA just because that's easier. And that is a clot busting medication that will, when it's given to someone who's having an ischemic stroke, has a high likelihood of breaking up the clot. When the clot is broken up, just like with Drano on your clog in the sink, when the clog is broken up, then water or blood in the brain's case can flow through. When blood is flowing through in the brain, then the areas of the brain get the oxygen that it needs to do all of the important things like tying shoes and carrying our coffee cup. The thing about TPA is that it can only be given within 4.5 hours from when the stroke symptoms started. So that's another reason why we really encourage people to come to an emergency room sooner, as soon as possible, because our ability to treat the stroke decreases over time. And 2 million neurons are killed per minute in a stroke, during a stroke. So even waiting 10 minutes for something to see if it's going to get better is a long time to wait. So we really encourage people to pay attention to these sudden signs of stroke and go to the emergency room very quickly. The other thing that we can do is we can go in and retrieve that clot. So I think I mentioned the snake that a plumber might use that is used to go in and grab the clot. This is theoretically the same thing that a plumber would use. And let me show, okay. Let me just show you. I'm sorry, I went ahead. Okay. So when we've got the clot in the brain, you've got the purple part, we're going in to see if we can restore blood flow so that that green area that's there can get the blood flow back so that it doesn't die. So I want to show you, this is what we call a cerebral angiogram. And so, oops, I'm using my pencil, you can't see that. So this is the big artery that comes up from the carotid, and then it comes up into the brain. All of this is the right side of the brain. All of this is the left side of our brain. Our brain is like a walnut and has two halves. So the reason this is lighting up on this side is because the doctors injected a dye or contrast into this artery so that it lights up under imaging. So this is the imaging of a 46-year-old man who came in with slurred speech and difficulty finding words, and then just weakness on the right side of his body. Now, when we look at these kinds of exams, in this case, we're looking for what's not there. And here we've got a cutoff. And our neurohospitalists and neurosurgeons know that there's supposed to be an artery that would continue all the way up here and feed this part of the brain. So we're seeing essentially a blank space. So this is a patient who did have a mechanical thrombectomy. So like that snake, we went in and we retrieved it and pulled the clot out. And there's the actual clot. So this is our before picture, and there's that cutoff, and there's that white space because no blood is getting through. And now this is where that cutoff was. And after we get that clot out, we've got blood flowing back up into that entire area of the brain. Now, an aneurysm, we talked about that's the bleeding type of stroke. And so the longer someone has blood leaking into their brain, the more damage is being done. It's a medical emergency, and we want people to come in so that we can treat them as quickly as possible. Aneurysms are treated in two ways. One of them is with a clip like this, and this is a pretty invasive surgery. That's like real brain surgery, where they're shaving part of your head and cutting in, opening up the brain, going in and clipping that aneurysm. And so there it is. That's one of our former patients who had an aneurysm rupture, had a surgical clip placed, and she's got a pretty nasty scar there. That's all done in the operating room, but we've had a lot of advances in this type of procedure. And now what we're able to do is our neurosurgeons can go in, and it's kind of like thread it in your hip, not your hip, your groin. They are able to put a puncture in your groin and go up, thread a catheter up that artery all the way to the aneurysm, and then they fill it with platinum. So it's a platinum coil, and then that fills that aneurysm up so that no more blood can leak out. And so this is another woman who had an aneurysm, and she had her aneurysm treated with a coiling, with that platinum coil. And so this is the incision in her groin. It's a lot less of a surgery. It still, has its risks. It still involves the brain, but it's a lot less of a surgery than the other woman had, who had to have her skull opened to get to the aneurysm that way. So we've made a lot of progress in procedures for stroke. So here is a kind of a graphic example of that catheter that's fed up into the artery and fills the aneurysm pocket with platinum. Now here is the before. We see this aneurysm is full of blood. It's dark, it's full of blood. After the coil is put in, it's very faint, and that's because you can kind of see the coils of the platinum coil, but it's filled up that space, and blood is no longer there. So that's exactly the outcome that we're going for. No more leaking. So when a stroke occurs, what do you do? The American Heart and Stroke Associations come up with this acronym, and hopefully some or all of you know it, or it's somewhat familiar. It used to just be FAST, and they added the B to it because people didn't recognize that a sudden onset of balance problems was actually a stroke, or that sudden loss of vision was a sign of a stroke. So the face drooping or numbness is a sign of a stroke. A is for arm, that arm weakness, numbness, or lack of movement. Speech difficulty, not being able to say the word that you want, or even being able to type if you're typing in a text or on the computer. That would be a sudden change in that would be a sign of a stroke. And then the T stands for time. It's time to call 911. This is not something that that you should hop in your car or put your spouse or friend in the car and drive to the emergency room or the urgent care. You call 911. One of the benefits of calling 911 is that the medics will alert the emergency department that you're on the way. They'll get an IV started. They'll get all of that history, and that's what really allows us to, or that helps us to treat stroke so much faster, because they're doing some of the work on the way into the hospital. So if you are having a stroke, or if you think someone else is having a stroke, call 911 and be aware of the time when the stroke symptoms first appeared. When we talk about that medication, TPA, we are only able to give it within 4.5 hours from when the symptoms started. If we give it anytime after 4.5 hours, what past trials have shown us is that the risk outweighs the benefit. So what is actually happening is the brain has gotten to a point where it's died, and if we give the TPA and we break up the clot, then after too long, then the brain is getting blood and it's not able to receive the blood because it's died, and so it just causes more damage. So that 4.5 hour window is very strict because of safety. TPA is quite safe when it's given in that early window, but it is deadly when it's given after. So knowing when those symptoms started is really, really important. It helps us decide whether or not someone is a candidate for the clot busting medication. So many people don't respond to symptoms because they don't recognize them. They don't know what they are. They're in denial. They think, oh, I'm just fine, or they come up with every other reason for why something's happening. And I think I've heard it all, but I usually will hear new reason why someone didn't come to the hospital every week or every other week. And some of those reasons are, well, I was tired, so I just went and laid down, or I was doing yard work, and so I thought that's why my one arm must have been sore, or I went for a long walk, and so I thought that's why. There are so many things that just we will come up with as humans to explain something to be less than what it actually is. Sometimes people think nothing can be done, and we know that's just not the case. Some people are worried about cost. Calling an ambulance and having transport to the hospital isn't free. And so some people, I mean, that's a legitimate concern. Some people think the symptoms will go away. Like I said, people will have NAP. I had one I'm not sure if it's a man or a woman, doesn't really matter, but was at the mall. So this was pre-COVID, and was feeling like the right side of the body wasn't working right. And so they thought, okay, well, we'll just stop shopping, must be tired, let's go check out a movie. And so they went to the theater and went to a movie. And then when they got up and walked out of the theater or tried to walk out of the theater, it was worse. And they're like, okay, yeah, we need to go to the emergency room. But I just keep thinking about that movie being, you know, almost 2 hours long, and that time, how much brain was being impacted during that time, because people just don't want to think it's a stroke. And, you know, we've got people here, doctors and nurses and care technicians and educators who all know better, and they will still kind of fall into that place of denial and not wanting to really recognize it for what it might be. And then some people just don't like doctors, don't like hospitals, and don't want to come. So let's talk about stroke recovery. 10% of people who have a stroke recover almost completely. That's not very high. And that is why that's really the primary reason that I'm sitting here talking to you guys today, is because if we can reverse the symptoms of a stroke through the clot busting medication TPA, or thrombectomy by pulling out the clot, or a coil by closing up a hole in an aneurysm, if we can stop a stroke while it's happening, then people will just have a higher likelihood of having no impairment from a stroke. 25% cover with minor impairment. What's minor is really hard to say, because if I can move my arm, but I can put my coat on, but I can't zip my coat up because I don't have that fine hand control or fine motor control, is that a minor impairment? For some people, maybe, but if you're a fly fisherman, or if you do needlepoint or crochet or write, you might really not think that that's a minor impairment at all. And then 40% experience moderate to severe impairments requiring special care. And I've heard most of my career that the thing that people are most concerned about is needing help, needing physical help, not being able to physically care for themselves, and needing to rely on other people to help them. And it's about 50% of people who have a stroke are in the position of not being independent. And then 15% unfortunately die. So stroke doesn't often kill people quickly like a heart attack does. I think that's another reason why people don't pay the same attention to a stroke as they do to a heart attack. So all of that bad news about stroke, and we're gonna wrap up soon with what we can do to prevent a stroke. So 80% of strokes can be prevented with healthy behaviors. So all of that stuff that we already know, that our doctors tell us about exercise and eating right, taking medications routinely as prescribed, all of those things can help to prevent or reduce our risk of stroke. Long-term effect is minimized with immediate treatment, and there are more and more people that are surviving and beating stroke. I said that stroke was top 5 cause of death for adults in the US. Just 5 years ago, it was the number 3 leading cause of death. So we are, as a community, getting better at identifying strokes when they're happening, getting people to the right care as quickly as possible, and then providing them that care, that it is now, we now see we've had a big change in the number of people who are dying from stroke and who are disabled. And I'll just tell you a little bit of a story. I mentioned that I've been doing this for about 25 years, and I do remember kind of being a new grad myself and having a lot of heartache about seeing the people who would come in with a stroke, and just how devastating a severe stroke in particular can be, and how their life was never the same. Even with a good amount of therapy, severe symptoms of stroke are hard to rehab from. And then I started working with the stroke program and seeing what TPA, what the medication did, and what thrombectomy did. And I now, every single week, and I'm wowed by it still, I get to see people roll in here having severe strokes and get to us in time that they can have TPA or a thrombectomy. And then I visit them in the ICU a little bit later that day or the next morning, and they are completely fine. And that is, I mean, it's science, but it's still a little bit of me thinks it's a bit of a miracle. And it is the most rewarding thing that I get to see, because people's lives are being changed for the better in a way that we didn't have the opportunity to do years ago. So I think that's it. I want you to be aware of what your blood pressure is. Keep it down. If you smoke, quit. If you have someone who loves who smokes, talk to them about quitting. Consume less sodium, lower cholesterol. If you're like me and have put on some of those COVID pounds, you know, work on losing a few of those and get physically active. If you haven't had a stroke, know what your risk factors are, if you have any of them, and work to reduce them now, so I don't have to ever see you in an emergency room. All right, we've got time for questions. Does anyone have any questions for me? Karen?
Can you hear me now? Yes.
I can hear you, yeah.
So from that, am I correct in thinking, even if you see a minor, if there is the minor TIA symptom, that you should call an ambulance then?
Yes. Yeah, so that is the you know, minor symptoms, I think, is a relative thing. I've talked a lot about dropping the coffee cup. You know, you think that, okay, if I got up out of bed and I went to the bathroom and I made my coffee and I got my coffee cup out of the cupboard and then I poured my coffee, and it's only then when I was holding my coffee cup and kind of the weight of it, my hand didn't quite have the strength or coordination to hold it, that it fell. You know, when you kind of add all that up, I see